Oh, hey, Chris.
Hey Chuck, how are you?
I'm pretty well. It's a beautiful day in St. Louis.
It is, it is. I felt hot today. Driving around in the car, it was so weird, but it felt really good.
I mean, morale is heading in the right direction for many reasons.
Yes, yes, it's been great, and it's been a very busy weekend in the D house. It's spring cleaning slash preparing to put the house on the market. So a lot of things are going on. There's a lot of sorting of things, multiple trips to Goodwill, and I decided to tackle doing some work in the basement. So
Oh,
it's
God. How long have you been in your current home?
We've been here for 4.5 years, and we never got our basement's unfinished, as you know, in our neck of the woods. It's a stone basement, and we haven't been good about maintaining for water reasons. So there was a lot that needed to be done. So I was power washing and mold treating, and got to do some painting in a couple of days. Doing the whole shebang, man.
I don't miss those days. Hopefully, I'm in my forever home, but you never know.
Yeah, well, hopefully we're moving into our forever home. We're doing that thing where we're waiting for our new place to be finished, because it's getting restored, and it's supposed to be done in a couple of months. So we're trying to time putting our current place on the market and hopefully it all works out. Otherwise, we might be in your basement.
You are welcome in my basement for sure.
The kids love the toys at least. So
Absolutely. Well, let's jump right in. Any reviews to share?
yeah, we've had a couple of great reviews. The first one I'll share today is from a current hand fellow, Tatiana Boyko. So, Tatiana, thank you for the review. 5-star review. So, we appreciate that. Says, what a great podcast. As a hand fellow, I really appreciate this collection of topics, which includes the perfect ratio of nerve, congenital, and sports. I will say she put nerve first. I think she's probably playing to you because we haven't really talked about congenital, but she's putting it in there. So, well done, Tatiana. Well done.
Tatiana, I think you were subliminally asking for more congenital. I think is what you were saying. That's the way I heard it, and so we will oblige you at some point.
I will include it in today's "What's New in Hand Surgery" congenital update.
Yeah,
That section will be a little short, but we'll say the words.
coming soon. So I wanted to actually, before I jump into a case, shoot, help me, Chris. I'm gonna have to edit this out. What's Dr. Chase from Stanford?
Robert Chase.
Robert Chase. Let me talk about that. Um, So before we jump into a case, I was fortunate enough to do a visiting professorship with the Stanford group, and it was fantastic. And thinking about your what's new in hand surgery for JBJS, made me reflect on a little due diligence I was doing for the Robert Chase program at Stanford. And so I did a quick literature search on Dr. Chase, and he used to do many years ago a what's new in hand surgery for, get this, the New England Journal of Medicine.
Ah, yes, I missed the boat there.
Yes. So by no means is JVJS the minor leagues, but it is not the New England Journal.
Yes. Are you going to bring it up again that you published in the New England Journal?
Did you know that I
Oh, I
published?
did. I didn't know. It's brand new information.
Yeah.
Next thing you know, you're going to be in the Atlantic and the New Yorker, and you'll completely have run laps around me. So thanks.
Big dreams, big dreams. Uh, so let me share a case. So, I trained at the World Center for Proximal Row Carpectomy, that is Cincinnati. And it's
It's
such
actually the when you get to the airport, it says Chili Five Ways and the home of the PRC.
home of the PRC. And it's so funny. Cincinnati does some great reunions out in Jackson Hole, Wyoming, where Dr. Stern has a place. And at one of these reunions, the fellowship alums are blessed with a great sense of humor. And so there was a case once presented that included excision of the trapezium and the trapezoid, and the suggestion for nomenclature was the DRC, given that Cincinnati is the home
Yeah.
of the PRC. So I'll be honest, I really like the PRC, but I don't like it perhaps quite as much as others, and I hesitate to do it on what I consider young patients. And I'm 50, so younger than me qualifies as young, especially laborers. But I did one this week in a patient with a heavy smoking history, inability to stop smoking, so 2-pack a day, was unwilling to stop smoking, and I referred him and the like, with severe arthritis. and it just seemed like the best way forward. And he was a 40-ish laborer, and I think it's going to work for him, and I think it's going to work for the long term. But I did lay crepe and suggested, look, if this fails, we can do a wrist fusion, no problem. But I didn't feel comfortable, and maybe I should have. I didn't feel comfortable with a four corner and a heavy smoker. How do you think about that?
Yeah, I mean, I would not have felt comfortable with that either. I mean, I think to me that shifts the balance more than anything else. We always think about age and demand, but that's predicated on the successful surgery. And that's the big thing about the scaphoidectomy four corner fusion is that you got to get that thing to heal. I think that I'd be interested to hear whether you think that the younger patients you've done a PRC in have problems with strength. I've had one patient comes to mind that's had a four corner fusion that is stiff and was told about stiffness ahead of time and still doesn't like it. And I did it because he is a laborer. But given the occupation, it made it very difficult for him to do his job, that amount of stiffness. So I'm just curious, whether stiffness ever is a problem for you, whether when you do four corners, excessive stiffness, and then on the converse, for your younger patients who you do a PRC on, what their strength is like.
Yeah, you hit on the two criticisms. The recent literature has been very clear that the problem with scaphoid excision and four-bone fusion is the complication rate and the hardware issues and the stiffness, etc. Um, I have to say, I've had my share of patients who are frustrated by lack of motion after a four-bone fusion, for sure. And I do tend to counsel them, if you get 60% of motion, that's good. And I think that's 60% of where you start, not of the contralateral side. But that,
Mhm.
we can show that to patients, we can demonstrate it. Until they live it, they don't like it.
Yeah.
And in the PRC, I think strength is pretty reliable. It's always been said that, you lose strength with the PRC. I don't think that's true. You take away pain. I've been pretty happy with strength with PRC.
Yeah, I think that the literature, the more recent literature has given PRC lovers a lot of room, a lot of reason to rejoice because they can use that procedure more and more. But still, I think that in your particular case with the smoking history and the concern for the ability to heal a fusion, I think that's the right call.
I certainly hope so. I certainly hope so. Time will tell.
Yes, and we should shout out that a lot of that some of the recent literature has come from our colleagues at the University of Utah, and I think one of our WashU residency alums, Nick Kasmers, has been leading the way. I think with Andy Tischer as well. So they've written some great papers on that recently. So
They've written some great papers on a lot of things. So they are
yeah,
really making a huge contribution. I totally agree.
yeah. I'm gonna say right here, Kasmers is the new Calfee.
Oh, wow.
That's a
It's,
bold statement, but I think it's gonna come true.
love it.
So why don't we jump in? We're now at part two of what's new in hand and wrist surgery. This article I think is already available online, but will be in the March 18th JBJS print issue. So this episode should be coming out right around when that hits mailboxes. We left off after the cubital tunnel part last time, so why don't we jump into the distal radius part?
I love this first article in the sense that I think, especially for those of you who are in training or in medical school, you have to, this is something I struggle with. When we think about distal radius morphology, we think about an 11-degree volar tilt, and that's what we preach, and then you have your inclination angle and you have your height and all that stuff. We don't really talk about this volar cortical angle. So I don't
Mm-hmm.
mean to steal your thunder, but I thought this discussion is really important.
Now, I remember reciting to myself as a rotating fourth year medical student 20 through 12, 11, 20 through 12, 11 to make sure I got the volar tilt right. But, there's just so much variability. So this is a really neat paper. The first author was Gandhi. And they looked at 273 uninjured adult distal radii, and they measured this volar cortical angle. And they found that angle, which is essentially what the where the plate is going to sit if it sits perfectly, can range from 23 to 43 and is a mean of 32. Now, I don't know which implant most people are using right now, but looking at the fact that the volar cortical angle of most volar plates ranges from 18 to 30, there's a chance of some mismatch there. And I think that really plays in when you're potentially using the plate as a reduction aid, which we all have tried to do at some point, and I still use that as part of my arsenal in terms of reduction tactics. I mean, how often are you using that, and how often are you considering whether it matches the patient's native angle or not?
I think about this every single time I do a case. And here's where I am. I mean, if you think about this volar cortical angle, which is really the angle on the volar, correct me if I have this wrong, but the volar cortex of the shaft, and then the angle of the radius as it heads towards the watershed line.
Hmm.
And so the tricky part when you're putting your plate is how distal can you put it and not cross the watershed? And how can you use it to aid your reduction exactly as you ask? What's really interesting to me is my problem is the opposite of what is implied with this paper is often I feel my plate is prominent with the volar, it has too much correction angle rather than too little. So I don't know how to reconcile that, but this is a really important factor. And I think about it every single time I do a case.
Yeah, I mean, I think especially with some of the more comminuted fractures and the ones that are very substantially displaced, we like to use that plate as a reduction tool, essentially distal first strategy, get it lined up, put it where you think it's going to lie. But then once you reduce the plate slash distal fragment construct to the shaft of the radius, you may be off. And I think that that is one thing to consider. And since reading this article and kind of processing it a bit more, I think I've tried to endeavor more about getting that reduction as perfect as I can before applying any sort of implant and relying less on the plate.
I think that's well said, and that is especially with a comminuted fracture. If it's a simplistic fracture, then using the plate is easier. And I don't need to restore volar tilt to be happy. Let's be honest. If I get the volar tilt to neutral, 5 degrees, 7 degrees, I'm happy. But what is more concerning to me is when the plate seems like it's not on the bone. It makes me worried about flexor tendons. I know the next article you reference is about extensor tendons, but obviously we also worry about flexor tendon irritability.
Yeah, but I think when you have the mismatch, the setup where your plate isn't exactly where you want it proximal to distal, and then you have a slight undercorrection, say you are accepting neutral, then your plate's more prominent. And that's what, some of the paper that I talked about in last year's What's New mentioned is that, and that's when you're prone to irritating the FPL. So I think that's a concern. I usually will. I used to settle more for neutral, but now I try to go for anatomic if I can.
Which gets to, and this will be a nice segue into the next article. So one thing I have traditionally done, and I may do it a little less now because of what we're about to talk about, one thing I've traditionally done is if I have a relatively straightforward fracture, I'll use a non-locking screw to bring the distal fragment down to the plate, meaning that screw is going to have to capture the far cortex, meaning you're going to have to drill through the far cortex. Um, and I think that's a really good technique. It does require wasting a screw if that screw ends up being long. But that helps to minimize the risk of plate prominence volarly with a possible risk of tendon irritation dorsally. So again, I'll let you guide the way, but it's a nice segue, I think.
Yeah, so I mean, that in doing that technique, typically when I'm inserting my distal fixation, because your best chance at seeing whether your screw is intra-articular on the ulnar side in that kind of volar lunate facet, lunate fossa part of the plate, is to fix there first. Because once you put a radial styloid screw in, it's really hard to see those ulnar sided screws. So I usually fix there first, and that's because the intermediate column is supposed to be theoretically more important. Um, I'm trying to capture the far cortex there. So the far cortex there is that dorsal ulnar corner fragment. There was a paper a few years ago, I think it was 5 or 6 years ago, maybe from, I think it was Japan, where they discussed the importance of this dorsal ulnar corner fragment. And I don't think it ever got published. I remember Dr. Gelbman always asking about it, and it never got published. But one of our current partners, David Rogan, got kind of interested in looking at this. And I think he started this work when he was at Mizzou, um, trying to see whether you could, how big that dorsal ulnar corner fragment typically is. Now, disclaimer here is that he studied this in postmenopausal women in terms of the size of the fragment for those that were getting CT scans. So it may not be the same for patients with a younger younger fracture pattern or type of injury. How often before reading this or thinking about this were you considering fixation into that piece? Was it only when you were using your bicortical screw to be able to plate down a bone?
No, I think it's a really important point because what has happened, and this is classic in orthopedics and every specialty, this pendulum swinging back and forth. And so we have become so focused appropriately on the volar ulnar corner that we've kind of said, well, don't worry too much about that dorsal ulnar corner because it's rarely important. I think there's some truth to it being less important comparatively, because if you don't take care of the volar ulnar corner, things aren't going to work out well. Often, if you ignore the dorsal ulnar corner, things will. But this paper does highlight why we shouldn't take that fracture pattern for granted. And we do need to capture it one way or another, especially when it's a buried fragment.
Well, I mean, even work out of our own group, Ryan Calfee, Lindley Wall writing papers about, obviously being careful not to irritate or, rupture the extensor tendons, and going with shorter screws and showing that you really don't need to be, all the way across from volar to dorsal with your distal fixation in order to have mechanical stability. But I think some people have just taken that to just drill, pop through, and just put in a 12 or a 14. But if you do that, you're likely going to miss this fragment. And I'd be curious, what your thoughts are in terms of whether you think that fragment has implications for the DRUJ, like subtle issues that can cause instability or pain.
Obviously, we're all biased by our own experiences, and knock on wood, I've not had that issue. But the paper is, captures a real sizable fragment. And so I think that's important to bear in mind. And if there's any uncertainty about that fragment as you're considering the fracture pattern, then the CT scan is an absolute benefit to your surgical planning.
So what David's paper showed, the one that we're talking about now, is that dorsal ulnar corner fragment in the postmenopausal female fracture pattern is typically 24% of the articular surface. So if you're putting your screws in and say it's under 75% of the volar to dorsal length, you won't capture that fragment. So I think most of us who drill and drill through the near and then kind of touch the far cortex but don't go through, you'll capture it if you just put your screws in too shorter than what you've drilled. But if you are less aggressive with your drilling because of the concern for the extensor tendons, you may not capture that fragment. It may not be a big deal, but in some cases it might.
I think that's well said. And we know that the dangers of the extensor tendons is probably twofold. Part of it is the actual drill, and part of it is placing a screw that passes that dorsal cortex, which can be hard to visualize. And there's a number of different techniques with the C-arm radiograph one can utilize. I don't mind drilling the dorsal cortex as part of my placement of screws. I really don't. I never have, as long as it's done meticulously using the sound feedback you get from the drill, as well as the tactile feedback not to plunge. To me, that's crucial. And that can be really hard with osteopenic bone. So it's tricky, but I am with you and I agree that those screws need to be more carefully placed. And hopefully, like you said, 2 millimeters short of the dorsal cortex should be good.
I worry a little bit, in the most ulnar uh, portion of the distal row, I'm less concerned about the EPL being there just because of where it is radial to ulnar, because you're pretty far ulnar to Lister's tubercle, relatively speaking. But as you get into those middle two screws on the distal row, that's when I really start to worry about the EPL. And I thought it was interesting. The next paper that is in the article is one from Duke, in which they use a proprietary implant, but they do a separate dorsal ulnar corner approach, and then put a screw in that interlocks. The distal end of the screw interlocks into the volar plate that they've already placed. And I thought that was a kind of an interesting idea. I don't use the implant the plate that they describe, so I haven't used that particular construct. But there was one case, I think about 4 or 5 months ago, where I thought that fragment was important and I really wanted to get it lined up because it was a younger patient. So I used a volar plate, but I made a separate incision, a mini approach to that dorsal ulnar fragment, and put a screw in with a washer just to hold that piece in place.
I think that is the right approach, and I've done that as well. It's so not a big deal to add a small incision dorsal ulnar, look at the fragment, reduce it. Even if you put a two-hole plate on or a screw with a washer, I think that is the right approach. And we all try to avoid that additional incision but it's worth it. It's no big deal. And I think it's safe and it's really important in the rare cases you mentioned.
So we talked about preferences in surgeons in terms of following the literature and kind of treating more patients non-operatively in the past. Um, and I think that we've accepted a lot of malunions, particularly in elderly patients. When it comes to doing osteotomies to correct those, what are your current indications for that? Because it gets into the next couple of papers to talk about the complications after osteotomies.
The most common issue is when you have an ulnar impaction situation and a dorsal tilt with shortening of your distal radius. At least that's the most common situation that I see. And so you're left with the age-old question in hand surgery: do I shorten the ulna or do I address the primary issue, which is the radius? And that's not straightforward. I can say that I've done it both ways, and I still don't know the best way to do it. And I think it requires a conversation. I am less, excited about doing distal radius osteotomies for a lack of inclination. So the patient who may be dissatisfied with the aesthetics of losing that radial inclination and having a bit of a radial deviation posture. I've seen that done. I haven't actually done that in isolation as an indication. So for me, it's usually the dorsal tilt causing a relative prominence of the distal ulna, leading to that specific issue. What have you seen as the primary consideration for an osteotomy?
Well, I mean, typically when we go down the initial talk about surgery versus no surgery, and I'm steering them towards non-op, I tell them to look at their wrist right now, and then look at their other wrist, and then we talk about the bump on the outside, the ulnar head, and I say, look at how it is now. It's going to look like that. It's going to have the zigzag. It's just going to be like that. And there's no way around that. I hope you're okay with that. And I was taught, I think, by you and Dr. Gelberman to tell people about that ahead of time, because if you don't, it might bother them. And you never know who's going to be the patient that cares about that. Um, and I think that, it is a multiplanar thing in my mind. I mean, I think that, the loss of radial length is clearly an issue in terms of the ulna also becoming more prominent, but that's in combination with the typical dorsal malunion.
What you said actually reminds me of another episode we should consider. There's a new distal radius fracture clinical practice guideline, which is out. And I think it might be fun to go through that together and talk about the findings. And the clinical practice guidelines, for those of you who haven't spent time with them or participated in them, are really a fascinating process. It's a real added benefit. And this one was put on by the Academy, which I think has been involved in almost all of them, if not all of them, in partnership with the Hand Society. And so I think it's a really impressive. The new one for distal radius is impressive, and it hits on kind of some of the stuff we're talking about now. So that might be a nice separate episode.
Well, let's do it. I'll put you on the spot. Let's do it on Clubhouse, and we'll invite people to join in and chat with us about it.
I've been toying with Clubhouse, just what I need, another social media venue.
If you didn't get in on Instagram and TikTok when they were starting out, it's ready for you, Chuck.
Perfect.
So when you do your osteotomies, when do you go dorsal versus volar? I mean, this first paper that we looked at, typically they went dorsal. They talked about, two different types of osteotomies, essentially bicortical with some distraction versus cutting the dorsal cortex, leaving the volar side alone, and then hinging it open. I think you go volar typically, right?
I almost always go volar. We should do what we're comfortable doing. There's not one tried and true approach. And so, there are reasons I might consider going dorsal depending on where the malunion is and various factors, but I almost always go volar. I don't mind creating an opening wedge osteotomy in that process. I typically kind of slide bone graft into the deficit around the radial side of the radius. That may be off the shelf, that may be iliac crest, depending on the patient factors. So I'm confident in the ability of hardware, current hardware to help me do the job. And therefore I am trusting of going volar.
And that's obviously, like we talked about, a few minutes ago, relying on the implant a lot of times to help dial in your sagittal correction.
Absolutely. And you have the strong the volar cortical bone to help you as well. So it's about, different listeners will have a very different approach. And, the
Mhm.
argument go where the deformity is often does imply going dorsal. But I've just been more comfortable volar, and knock on wood, haven't had any regrets.
Now, have you noticed your rate of volar plate removal for this indication different than your rate of volar plate removal for an acute fracture?
Yeah, I don't recall taking any plates out for the osteotomy situation, but I certainly have taken my share out for fractures. Again, very low percentage, but I don't recall any for osteotomy. Do you have a similar experience?
Yeah, same here. I don't do a ton of osteotomies. I feel for me it only comes up a handful of times a year. And in this case, this paper, which was the first author was Hugverdian. They had 10 patients who had difficulty healing that osteotomy, but then also they had a 6% volar plate removal rate, which is, I think, a little higher than what most people would report in their own practices and what's reported in the literature. Have you noticed any patients having a hard time with healing the osteotomy?
It is really rare, but yes, I've seen that. And we expect even an osteotomy to be healed by 8 weeks, but what I've experienced is that sometimes it just takes longer to get there. And so we have to be a little more patient. And so, yes, I've had a few take 4 to 5 months to heal. And I've even gone back to the operating room once or twice to add bone graft. But thankfully, it's more about debridement and adding bone graft rather than revising the hardware. So yes, it happens, of course, but it's just rare. It's a great area that likes to heal, thankfully.
Well, there was another series that I touched upon. The authors were the first author, Sherko. It's actually Tamir Rosenthal's group. They didn't have as many non-union issues, but they also had a higher volar plate removal than they typically would have. They said four cases out of 37. So I think that's something to consider. I mean, it's when findings are present across papers from different institutions, something that should give us pause.
It should. And the other thing that should give us pause is it's been 15 minutes and we hadn't talked about nerves. So I think I know where you're going next.
Well, I'm going to spare you the plexus conversation for what's new in nerve surgery, but this was one that I think the radial nerve part I think would be really interesting. So, one of the people that has been very prolific in terms of publishing in nerve in the last 10 years has been Jaime Bertelli from Florianopolis in Brazil. He was actually somebody I was supposed to visit as part of the traveling fellowship and never got to do it, or haven't yet. But he published a really interesting paper in JHS, and he looked at 14 patients who were less than a year out from their injury, who got nerve transfers for a radial nerve palsy. Then looked at 13 patients who were more than 15 months out from their injury and had tendon transfers. Now, clearly, it's not going to be perfect methodologically, but it is good to see a comparison type study. And what he found was that wrist extension is pretty reliably restored with both nerve and tendon transfers, which I think most of us would expect. Finger extension was very reliably restored. M4 finger extension restored in all tendon transfer patients. But in the nerve transfer patients, there were two cases that had complete failure. So that's 2 out of 14, which is still pretty good for a nerve case. But in the setting of having tendon transfers as an alternative, that leaves a little bit to be desired. I mean, how do you kind of think through the? I know you don't do the nerve transfers, but how do you think about the tendon transfers in terms of success rates?
Well, let's be clear. I don't do the nerve transfers commonly because I have partners who do it really well. I think what we're seeing is almost, and this is not totally fair to say it this way, but there clearly have become two schools of thought. Some of that is the surgeons who have always done this with tendon transfers and been happy with their outcomes continue to use tendon transfers. And others who see themselves more as nerve surgeons are looking for supportive evidence, and this is certainly good supportive evidence for this approach of using nerve transfers. I think it's a really fascinating question. The science is probably never going to catch up and prove something definitively. And so I think it's okay to have different approaches. But wow, this is pretty compelling.
I mean, so 12 out of 14 with M4 finger extension, and that's, compared, that's independent finger extension as opposed to a tendon transfer in which they would all come up together. That's 86%, which for a nerve procedure, that's about as good as it gets. But still, there's still 14% that didn't get what they wanted, but the tendon transfers are still there as a backup.
Did you just do that math in your head?
No, I took out my calculator. Don't worry.
Okay, just
I
check.
don't do any math in my head anymore.
I was gonna be impressed.
But one interesting finding that was present in both the nerve transfer group and the tendon transfer group was that thumb MP extension was poor. And they had Jaime reported a 30-degree lag in thumb MP extension. Has that been your experience doing tendon transfers for radial nerve palsies?
Yeah, and I'll be honest, I think the finger extension and radial nerve tendon transfers and the thumb extension can leave a lot to be desired, when you're doing tendon transfers. So I think it's about expectations. And let's be honest, if you can restore wrist extension, you have a happy patient. Anything on top of that is typically just a bonus. But hey, we're not shooting for just satisfaction. We're shooting for a great result. And if nerve transfers may get you closer, then we all have to think about it.
So the follow-up paper that he wrote was in order to address that lack of thumb MP extension. He actually did a second nerve transfer, which I'm sure you're totally digging. But taking essentially the same nerve you would take for an AIN supercharge or end-to-end for an ulnar motor transfer, taking that nerve and then transferring that to the distal portion of the PIN before that distal portion of the PIN innervates the first, second, and third compartments. And he only did it in 5 cases, but he did show full thumb MP extension in 2. And then the MP extension lag was 15 degrees, 15 degrees, and 20 degrees in the remaining 3 cases. So maybe a long run for a short slide, but that's pretty interesting. So I think that, like you're saying, like the science may never be perfect in terms of the clinical research methodology and the rigor, but it's compelling stuff.
So presumably this is through the interosseous membrane. So it wouldn't be a huge stretch as far as technical or approach or anything like that.
Yeah, no. So he talked about the technique, and it's able to reach without tension. The donor to recipient axon ratio for those nerve nerds that care about that was 0.65 to 1, which is clearly acceptable and close to being ideal. So I think I want to do it in the lab. I'm waiting for the right opportunity for it to come up as a case, but as expected, Bertelli's pushing the envelope and reporting some really interesting stuff. I think it makes us all kind of think about where we could potentially change things. Again, it also kind of depends on just like when the right patient comes up.
Absolutely. Wasn't there one more AIN centered article?
There was, but before we jump to that, I think it is probably for anybody who is kind of thinking about areas to explore. If you're, a younger, early career surgeon, there's no comparative study on nerve transfer versus tendon transfer in the first year when they're both kind of, options that'll be considered. And maybe Jaime is working on something, but the papers that are out there are nerve transfer early or tendon transfer late. So I think that in that first year is kind of where the clinical controversy lies. So I think that's one thing to consider. And then the time frame for recovery is the other thing that is one thing that I tell patients. So I had a patient who, different scenario, we were talking about a plexus thing, but we were talking about tendon transfers or nerve transfers and whether she was willing to wait the year, 15 months, and she's 70. So I honestly, I steered her toward the tendon transfers because I wanted to get her a result that she could use early on and be quite reliable.
With a good tendon transfer, I don't know about you, but if I have a good transfer with a nice strength of the transfer, I'll get them moving at 2 weeks, which can be really impressive in the right patient.
Yeah, we can talk about that in our next episode. It was a really interesting case. I did it wide awake. So,
oh God! All right, let's do
it. So the last nerve paper that we'll cover for the What's New was, of course, controversy about supercharging. Now, I'll be very clear. I think that supercharging in the setting of trauma is different than supercharging in the setting of cubital tunnel. And the issue I have with the papers that were published initially is that everything was lumped in together. So I'm glad to see that there is a paper specifically for ulnar nerve trauma. And this is the first author was Corey M. And they looked at 21 ulnar nerve injuries and randomized patients to repair alone, meaning repair/grafting of a high ulnar nerve injury. And then 11 of them were treated with repair and supercharged reverse enticide nerve transfer, AIN-PQ, to the ulnar motor branch. And the injuries, the eligibility were an injury above the elbow to the ulnar nerve or 10 centimeters distal to the medial epicondyle. That's a big difference, in terms of, whether you think something's going to come back or not, presumably in an adult. So that is one of the issues I have with this paper, is that that's a wide range. Now, clearly it's hard to randomize patients to a nerve surgery study. So maybe that allowed them some leeway in terms of eligibility and enrollment. Their results suggest that doing a supercharge with the nerve repair grafting is better than nerve repair alone, which that's not surprising to me. But what I think the study that needs to be done is one that is more restrictive in terms of levels of injury, but then also looks at a supercharge versus an end-to-end nerve transfer. Because if you look at the results for an end-to-end ulnar motor to AIN, or AIN to ulnar motor nerve transfer, that's a really good result in the literature. It is in the high 80s, but we just don't know about the supercharge versus end-to-end. So I think that's one thing to consider.
Yeah, and I totally agree. And I also personally am interested in the concept of just a severe cubital tunnel potentially supercharged in addition to a transposition, because those patients can be very frustrating, and they can leave unsatisfied no matter how well you deal with the transposition alone.
Yeah, and I applaud. Obviously Susan McKinnon's been an innovator in this area, and we had the opportunity to have her on firsthand recently. And she has really pioneered the use of that surgery, and then rightfully so has tried to be rigorous about indications now. And the work that she and Holly Power have done looking at the motor amplitudes and trying to apply that to when to supercharge versus when to not, I think is useful, because I think a lot of people have been very enthusiastic about using the nerve transfer in this setting, and perhaps the indications are not as tight as many of us would think they should be.
Agreed. Agreed. All right. Well, should we come back again for a part 3 and finish this off? This great piece of literature?
That's my last year doing it, and I appreciate you saying it's great. It was a lot of fun writing it. I don't know what I'm going to do without pouring through the journals next year. I'd like to say that I'm going to do it anyway, but I probably won't. So
Hard to believe you'll find that kind of time. You'll do it a little more superficially if you do.
yes, perhaps. Well, all right, great. Well, I'll join you next week for the next one.
All right. Sounds good. Have a good day.
You too. Bye.